Monika Sarkar, a transplant hepatologist from the University of California, San Francisco.
My name is Lisa Coscia, and I'm the Senior Transplant Coordinator for the Transplant Pregnancy Registry International.
So thank you for tuning in today to learn about reproductive health in the setting of transplant. So many women who have chronic end-organ disease who are awaiting transplant actually no longer have periods. So the idea that you could potentially get pregnant after transplant may not come to mind. But fertility is actually rapidly restored after transplant. Women can start getting their menstrual periods as early as the first couple of weeks after their operation, and they can actually get pregnant as early as the first month. So it's really key to be having a discussion with either a women's health provider or your transplant provider about family planning, and having that discussion both while you're on the transplant wait list as well as through the course of your transplant. So now we'll be talking about a few different contraceptive options. The first one I'm going to discuss is the intrauterine device, or IUD. And this is the agent that I most often recommend to my own transplant patients. And they come in two general types. There's the hormonal IUD and the copper IUD. Now the hormonal IUD you may know as the Mirena or Skyla. They can last anywhere from 3 to 5 years, and many women like this for the feature of lightening of menses. So some women will have no or few menses while they're using this type of IUD. In contrast, the copper IUD can last much longer, so up to about 10 years, but it is associated with more cramping, heavy menstrual bleeding, so it might not be ideal for women who have post-transplant anemia, for example, or lowering of their red blood cell counts. Now, there are a few myths that IUDs might be less effective in transplant recipients, or that they might increase your risk of infection, a type of pelvic infection called PID. We actually know that that is not the case, and these are some of the safest and most effective agents in the setting of transplant. So now thinking about the next option, the combined hormonal contraceptives. So this contains an estrogen and a progestin. And it's really the estrogen that is associated with some increased risks, including potential increase in your blood pressure. It can also interact with some other medications that you might be taking in the setting of transplant. And it can also increase your risk of blood clots. So this particular one's very important to discuss with your provider if you're interested in a combined agent to really know if that's the safest option for you. As compared to the IUD, these are less effective. And one point about the IUD is that you can actually have that inserted anytime during your transplant course. Before transplant, some transplant centers will actually insert it at the time of transplant or following your operation. So now moving on to talk about the progestin-only agents. What's nice about these agents is that they don't contain estrogen, so there's no associated risk of elevating your blood pressure, no increased risk of blood clots. The mini pill is one formulation, and it does require taking the medication in the same window every day, so it's stricter compliance than if you were taking a combined hormonal contraceptive pill. The depot shot is a little bit more convenient. So women can have this shot injected once every 3 months, so pretty easy, but it is associated with some decrease in bone density. So it's important to discuss that particular aspect of the depot shot with your provider. And the last one is the implant. So this is injected in the subcutaneous tissue in the arm, and like the IUD, it has a very low failure rate, so very safe and effective in the setting of transplant. There are some other options, non-medical, non-medication-based options, such as barriers like the diaphragm or condoms, for example, withdrawal or rhythm methods. It's important to know that all of these are high failure methods, so we would not advise women in the setting of transplant to use these as their sole agent. Now, in a little bit, Lisa will be talking to you about Cellcept, also known as Myfortic or mycophenolate. Now, that is one of the most dangerous medications or transplant medications in terms of risk to the fetus. So if you are using one of those medications, we advise that you use a highly effective method, such as an implant or an IUD. And if you're using any of the other options that I mentioned, it's very important that you use a combination of 2 different agents. Now, for women who are really confident that they don't want to conceive in the future, there are also surgical options, including tubal ligation or a vasectomy for your male partners, if that is a better fit for your lifestyle.
So now we're going to go to those patients who would like to plan a pregnancy or thinking about being a parent after their transplant. So there are some pre-pregnancy guidelines, and also you have to remember that each organ recipient is unique, and it's important to talk to your transplant team ahead of time because there are some patients where pregnancy might not be the best choice for them. So these are our general pre-pregnancy guidelines. We want patients to be at least healthy for about a year after their transplant prior to thinking about conception. So good general health for at least 1 year. And our really critical point we've found is that patients must have stable graft function prior to becoming pregnant. So you really want to make sure that your transplant is working well prior to conception. Also, Monika mentioned the immunosuppression. So I like to break our immunosuppression down to 3 different categories. So what we consider to be okay to take during pregnancy is tacrolimus, cyclosporin, azathioprine, and prednisone. Overall, we've not seen any problems with pregnancy outcomes and any effects on the fetus. However, like Monika said, the mycophenolic acid products, brand names Cellcept and Myfortic, we have seen an increased risk of miscarriage and a specific pattern of birth defects. So babies are born with an ear deformity, some facial deformities, and sometimes some cardiac deformities. So you really have to talk to your transplant team because there are safe alternatives that you can be changed to prior to conception, but it's really important that that you do this in conjunction with your transplant team because you also need to know that you need to take your medications during pregnancy because we want a healthy mother, which will help with her healthy pregnancy and healthy baby. We really don't know about a couple of the medications. The sirolimus, everolimus, and belatacept, we just don't have enough outcomes to form any definitive conclusions about taking these during pregnancy. But sometimes the benefits of taking these might outweigh the potential risks of taking those medications. And also, it's important that if you have high blood pressure or diabetes, that these are well controlled before going into pregnancy. So what are the pregnancy outcomes? So overall, about 75% of the women will have a live birth. The babies are usually born about a month early and weigh about 5.5 pounds. This can vary by the different organ recipients, like I said, but overall they're healthy and developing well at follow-up. Because the organization that I work with, we follow patients every 2 years after their pregnancy as well. I also get the question very often of, can I breastfeed after I've had my baby? And the same general rules are followed with the immunosuppression. So we think it's okay when you're on tacrolimus, cyclosporin, prednisone, or azathioprine that you can breastfeed. And if you need to be switched back to one of the mycophenolic acid products after your pregnancy, it's probably best that you don't breastfeed while on those medications. So how can you find out more information? So we have a great organization. It's the Transplant Pregnancy Registry, and this is how you can get in touch with us. And you'll talk to me or one of my colleagues. And there's also patient brochures available through the AST website and through the International Transplant Nurses Organization.